Welcome to Voices of Change, a podcast for the Get the Medications Right Institute. We are on the cusp of a new era of specialty medications and gene therapies that will transform care. But we are also seeing tremendous waste. Annually, over $528 billion is wasted, and 275,000 lives are lost due to non-optimized medication use. Misuse, overuse, or underuse of medication therapy can lead to treatment failure, a new medical problem, or both. Consider some of these statistics. 1 in 10 Americans takes 5 or more prescription drugs. More than 75% of all physician office visits result in a prescription for medication. Annually, more than 4 billion prescriptions are filled in U.S. pharmacies, and 50 to 75% of patients do not take their medications as directed. But there is good news. There are opportunities to control the loss and waste, whether you are involved in receiving, paying for, or delivering care. Living in a world where patients get the right medications the first time is attainable. That's what you'll hear about on Voices of Change. And here's your host, the Executive Director and co-founder of the Get the Medications Right Institute, Katie Capps.
Hello, everyone, and thanks for joining us today. Today, we're going to speak about an innovative care coordination system that's emerging in Eastern Washington State. Empire Health Foundation is providing funding to develop and implement a care coordination system that brings pharmacists and care coordinators together to simultaneously address medication-related problems and the associated social determinants of health that are impacting the patient's ability to achieve the intended benefits from their medications. The program is designed to support and supplement the primary care provider's care plan and to identify potential medication-related problems, social barriers, and barriers that reduce medication effectiveness. Now, that program is called the Medication Care Coordination, or MCC for short, and it's been developed as a collaboration between Empire Health Foundation, Aging and Long-Term Care of Eastern Washington, and the Rural Health Resources Community Action and Medication Review, Inc. The Washington State University School of Pharmacy is providing academic resources in support of the program, and they've generated several articles on the findings from early pilots. The Alliance for Integrated Medication Management, a GTMRX partner, or AIM, for those of you that are familiar, is providing strategic program design, management development, and implementation support to program partners. Now, on today's episode of Voices of Change, we have several representatives from this very impressive program. And I'll introduce those individuals before we have a conversation today. Jeri Rathbun is the program officer for Empire Health Foundation. Jeri has been with Empire since 2015 and has supported rural and tribal partners with the implementation and management of programs focused on improving quality of life for older adults in Eastern Washington. Also with us today is Candace Anderson, PharmD, from Medication Review, Inc. Candace received her Doctor of Pharmacy from the Washington State University in Spokane. She has played a key role in developing the pharmacist role in medication care coordination and has seen a majority of the MCC patients. Dr. Robert Crittenden also joins us today. Bob is a health policy advisor. He's self-employed. He has served as a senior health policy advisor to Governor Jay Inslee. He served as an executive in residence at Cambia Grove, a healthcare innovation hub that bridges the gap between entrepreneurs and traditional healthcare sectors. Bob was a family practice physician for over 20 years. First, I want to welcome all of you to the program today. I'm delighted that we have an opportunity to speak with you this afternoon. I'll start my questioning with Jeri. Jeri, I understand that Empire Health Foundation serves the Northeast Washington region, and you've been working for many years to develop a cost-effective way to deliver CMM services. What does this effort look like, and why is it something that a regional health foundation like yours is interested in?
Yeah, thank you so much. And thanks for having us here. And I'm just really excited to be able to share about this program. So, to answer your question, at Empire Health Foundation, we're really interested in improving health outcomes and quality of life for the people in our region. And when we look at the rural communities in our region, we know that they tend to be older than our urban communities. We know that there are higher rates of chronic conditions, and that's with many people experiencing multiple chronic conditions. So, along with those chronic conditions, people often have a high number of medication prescriptions that they're taking as well. And if those medications are not actively managed, particularly alongside a person's lifestyles, their life situations, and their behaviors, it can really result in some big impacts on the quality of life and some very serious and dangerous health situations for those people. So, in working with some great service providers, we realized that our region did not have the appropriate systems in place to deal with these medication-related challenges. About 6 years ago, we convened a steering committee of both institutional and community providers to help guide the development of that necessary system to address those challenges. And through this effort, we learned 3 key things. The first is that we really needed to design a delivery system that could reach the difficult to engage populations. I'm sure many care providers can relate to the situation of having people who really need services the most and having the traditional health systems and health plans really failing to be able to reach those people. So that's really when we leaned into this idea of community-based care coordination as a powerful tool that leverages trust for behavior change. And really, at the center of our model is a community-based care coordinator who is in the home, working alongside that client as their advocate and building that trust with them and acting as the bridge with a tele-based pharmacist and the primary care provider. So in a 3 to 6 month period, this team addresses medication-related problems, the related social barriers a person might be facing, and they foster the client's own skills, confidence, and knowledge to better self-manage their care. The second thing that we learned is that we really had to build the infrastructure for this model. The advanced medication care coordination position that I just mentioned did not exist before we started this work, and we really struggled to find access to the clinical pharmacist that would have the capacity to be able to engage in this care model. So that's really when we partnered with the University of Washington College of Pharmacy to create a curriculum and training to support these new professional workforces. And then we were really fortunate to have the clinical pharmacy piece brought to life through a partnership with Medication Review and the great work of Candace Anderson, who's joining us today. So the third thing that we learned, and this is really the piece that we're still actively engaged in, is figuring out how to restructure the payment system to finance this care model. So we're really fortunate here in Washington State because care coordination is a priority with our state agencies, and there are a few successful programs in place, including one that's called Health Homes. And we're really working on partnering with these state agencies and the managed care organizations in our region to demonstrate the cost-saving potential of our medication care coordination model.
I think that's terrific. And you are to be commended for recognizing that the value and importance of interprofessional teams in both building trust and bridging activities to ensure that care is coordinated and managed appropriately. So kudos to you for not only recognizing that, but building an approach to this that is set up for success. Candace, I want to move on to you. You've seen a majority of the patients in the MCC program. What are the patient situations that call for this kind of service or this level of effort? And in what way is this a new and exciting role for the pharmacist to take on?
Yes, and thank you for having us today. Happy to join this discussion. So, our program focuses on patients who have a variety of medication therapy problems and who require comprehensive medication management to improve the outcomes of their disease states. Their medications have become more of a problem than a solution, and without the help of a pharmacist to help them understand their medication regimens, they're likely to experience continued complications and even more frequent ER visits and hospitalizations. These circumstances, of course, are very difficult and expensive for these patients, which places an avoidable burden not just on the patient, but on the healthcare system overall. So we have seen the positive impacts of this program on several of our patients, where we have helped to improve medication adherence, avoid hospitalizations, and improve clinical outcomes.
Here, Candace details a common patient story of why we need a better way to manage medications. We at the Institute are consistently developing tools to help all the various stakeholders in the team-based care model, and patient stories can be powerful demonstrators. If you or someone you know has a patient story that they would like to share, please reach out to us. Now, let's get back to Candace.
One patient, for example, that I had the pleasure of consulting with was a 57-year-old male. He had multiple chronic conditions, including reflux. He had high blood pressure. His lipids were not under control, and he also had type 2 diabetes. And for these conditions, he was taking 15 different medications. And one of the medication therapy problems that we identified that was an issue for him was involving his medication adherence. And he was taking a medication for his diabetes that required refrigeration, and it was a once weekly injection. And so because this medication was stored in the refrigerator and away from his other medications, he would forget to take his weekly dose. And so at the time that we saw him, his A1C was 9.4. It was well above target, and his diabetes was not well controlled. And during the consultation, he was informed that his medication may be stored unrefrigerated for 28 days, which previously he had been unaware. So I counseled him on this medication. I let him know that once he opens it, he can store it with his other medications to help him remember his dose and to make sure that he tosses it after 28 days. Some other medication therapy problems that we identified with this patient include him not understanding his medication directions. He had a duplicate therapy in there, some medication interactions, and then as well as incorrect administration, all of which were discussed with the patient during the consultation, and he was counseled on the appropriate use of his medications. Additionally, some recommendations were submitted to his provider, including a referral to cardiology. He was overdue for a follow-up, and then also recommendations to switch 2 of his medication doses to help decrease his pill burden. So by the time we saw this patient for his final consultation, it was 3 months later. His A1C had dramatically improved. It had gone down to 7.9, and he had reported feeling much more confident and empowered about his diabetes management. He was taking into consideration the recommendations that I had provided to him at the initial consultation, and that had been really helpful to him. He had been seen by a cardiologist. There were no concerns, and he was told to return for a follow-up in 2023. And at that time, he had no further medication therapy problems. So he was discharged from our program, and he was very pleased and grateful for the help that we were able to provide. And then as far as things that we've seen in this role that are very new and exciting from the pharmacist's perspective, having that time with these patients across several visits, really spending time with them, interviewing them, really helping them to understand what their conditions are, why their medications are important, and why it's important to stay adherent and keep their conditions under control so that it doesn't lead to to further complications. We get to develop solutions with these patients and work with them as well as with their physician to resolve medication therapy problems that we identify and make sure that by the time they're completed or discharged from our program, they've resolved those medication therapy problems and they feel more empowered to manage their conditions and have a better understanding of the importance of their medications and their regimen. I've also been able to see integrative communication where we're able to create conversations that are facilitated by our advanced medication care coordinators who help to bring the pharmacist and doctor together. And as a team, we all work together to help our patients resolve these medication therapy problems that we identify. And then lastly, being able to see the direct impact of the work that we're doing with these clients as far as providing comprehensive medication therapy management, and then also following them closely to make sure that their medication therapy problems are resolved has been very impactful and nice to see, and I think unique to this program.
So thanks, Candace. I've just got a couple of follow-up questions on that. It's such a comprehensive and robust program that is impressive in terms of the interaction with patients. I'd be interested in to hear from you. I'm going to ask you two questions, and you can respond to both. What have you seen to be the reception from the patients? And secondly, what you've described is it's an expanded role. I can't say that it's a new role for clinical pharmacists. I would say rather, it's an expanded role for clinical pharmacists, more comprehensive, as you mentioned, and iterative in its very nature. But in what way is this different from the way that you may have treated a patient in the past or managed the medication therapy problems of the patient in the past? So let's first go to the question of what's been the response from consumers or your patients, and then secondly, how is this different as a clinical pharmacist from your standpoint?
Yeah, thank you. And those are both great questions. And I'll take your first. We have received great reception from our patients as far as their satisfaction with the program and really their gratitude for the time that we've taken to work with them to help them understand their medications, the importance of their medications, to help them improve their adherence. So, for example, we have a lot of patients who they forget to take their medications or their medications are very unorganized. So together with the advanced medication care coordinator, we'll work with them to have their medications bubble packed by a pharmacy, to have their medications mailed to their home, even in 3-month supplies, if that's possible. All of this helping the patient to improve their adherence. And they've all been so wonderful and so grateful for what we've been able to do for them. We've had some patients even recommend this program to friends, family, neighbors. So we've had nothing but positive reviews as far as what we've been able to do in this program for our patients. And then your second question, comparing this expanded role to other clinical positions, what I think is unique, and I think that you are correct in that this role is more of an expanded role. What's nice in this role is that we are able to spend as much time as we need with our patients to ask them really thorough questions, not just about their medications, but even social factors that might be impacting their medications or how they're taking their medications. Being able to really identify and really look through not just what they have going on from the medication side, but also socially, looking at those together, and then working with the patient across multiple visits to see how we can better manage their medications, how we can minimize, if not completely eliminate, any medication therapy problems that they're having, but also to help them make sure that they feel more empowered about their medication regimens and that they understand what medications they're taking and why it's important that they take them. Being able to follow these clients across multiple consultations and follow their progress, I think, is something that's been unique to this role.
Okay, that's great. And I'll be interested in hearing more from Dr. Crittenden about that interprofessional collaboration with the clinical pharmacist. But I have one final question before I move on to him. And that is at the Institute, we are certainly mindful that, there are a host of medication therapy problems. Two of the distinguished fellows of the Institute published a paper in 2018 that found that $528 billion a year goes toward non-optimized medication use. And it, of course, creates significant waste, and 275,000 lives are lost a year. And that waste is measured in additional hospitalizations, ER visits, and long-term care visits. But we're also interested in the Institute on the recognition and the importance of pointing out that medication therapy problems go way beyond adherence. As a matter of fact, adherence is just a small percentage of the total medication therapy problems that must be managed. And it sounds like you certainly address those in the evaluation with your patients. But areas like like inadequate therapy, or the dose being too high, or adverse reaction, or even unnecessary therapy. Is this medication needed at all? Those are things that are also evaluated as part of that process. Can you speak to the way in which you approach that when you are looking at a comprehensive medication management process versus what we might find in more conventional, discrete activities that don't allow you to do that over an extended period of time, Candace?
As Katie just mentioned, lack of adherence to a medication is only a small portion of the larger array of medication therapy problems that must be addressed. In fact, it only accounts for about 15% of all medication-related problems. There's not enough focus on other problems like inadequate therapy, which accounts for 57% of medication problems. Adverse reactions accounting for close to 15%. Dose too high at close to 10%, and unnecessary therapy is close to 7%. This large range of medication therapy problems, not just adherence, lead to the unnecessary hospitalizations, more provider visits, unneeded emergency room visits, and additional prescriptions. Altogether, they create $528 billion of waste and unnecessary costs due to medications that are wrong, missed, should be stopped altogether, or are not taken as intended. Let's listen further.
Yes, and this is a great question, so thank you. When we are looking at medication therapy problems that our clients could be experiencing, we use the PQA medication therapy problem categories framework that was developed by the Pharmacy Quality Alliance. And they separate medication therapy problems into 4 categories. The first is adherence, another is effectiveness, a third is indication, and the final category is safety. And then all of those categories are broken down. So there's several different items within each category that could be a medication therapy problem that the patient is experiencing. So like you mentioned, for example, they could be taking 2 drugs that are interacting with each other, and that could be causing a safety issue. They could be taking a medication for a condition and their condition is not improving. That condition is refractory to their medication. Maybe their dose is not high enough, maybe their dose is too low, maybe they're taking something that's completely inappropriate, there's no medical indication. And so that's what we look at. That's how we determine what medication therapy problems the patient is experiencing, and then from there developing strategies and recommendations on how we can improve those medication therapy problems for the patient by the time they're done with our program.
Okay, terrific. Thank you so much. Well, now I'll move on to Dr. Crittenden. Bob, you come at this work both as a physician and as a health policy advisor to state officials. I think that's a terrific combination. In what ways does this program make it better for the physician and their ability to serve their patients? And what impact can this have on how the state sets up its own healthcare delivery system?
Katie, both good questions. And I ran a clinic at Harborview, which is our big public hospital in Seattle, really covers most of the state. And we had a lot of medication-related problems, and we took care of them. And people ask me, well, why do we need a medicine management program when in fact we have pharmacists on our staff or whatever? And the real reason is that we work in teams. We do a lot of good things. We had a pharmacy residency program at our clinic, but we did not reach those people that didn't come in. We did, now we're moving now towards a active management approach to healthcare. We can't just wait for people to come in. And a lot of people have problems that we do address when they're in the clinic. But in fact, what we're finding as doctors, as well as society, is that many things impact somebody's ability to be healthy. Part of that is medications, and they're very complex. Particularly, I had a number of patients with 15, 16 medications. But those people also have other social problems, other that maybe their mental health, maybe their housing, other things. And what happens is to really reach everybody that you need to, and we're finding this really in Northeast Washington, where this program is, as well as almost everywhere in the state, is that you have to go out and connect with those people. You have to see what goes on in their home. Where do they keep their medicines? What are they actually taking? All those things are very difficult to do from a doctor's perspective, and you need to have an ability to reach out like that. So yes, we need to have teams, and those teams, though, need to involve people in the community who can reach out and connect with people. The other thing is that, there are a Medicaid management program like this really is based on trust. It's the ability for people to accept somebody to come in, or at least talk to them and actually assess what's going on and make good recommendations. Some of the interesting things with this program were that when you start working on medication problems, you realize that many of their problems are much more complex. They have housing problems, the mental health problems, the other problems that interfere with taking their medication appropriately. And you need to play the whole piano. You need to work on all those things together. This program allows us to do that. So I think that the trust levels, the ability to connect with people and to really actively manage them from the home. And I think when you look at the team that a doctor has to work with, that having a pharmacist is good, having that ability to work into the community and have that trust level at the front end is really important. So from a physician point of view, it's really important. And as I've worked with a lot of physicians around the state on related issues, they're dying literally to help people in their homes try to figure out how they can connect most effectively, and also to figure out ways to address these other issues, not just the medicine, but the other issues as well, because they do impact them. Now, interesting from the state perspective, there's a lot of care management going on in a state. We have probably close to 30 programs separately funded in silos in our state that have to do with care management. None of them directly work on medication. Some are indirectly doing that. But what the problem is from a state policy perspective is that we give money to managed care organizations. We give money to health homes. We give money to a lot of different groups, and they all are trying to do a good job. However, what we find is the engagement rate, and I think Jeri mentioned this, is the engagement rate is very low in most of those programs because you can't have a local representative from 30 programs in Cooley, Washington, or in Davenport, Washington. You probably get a phone call, and trying to develop a trust level by just a phone call just doesn't work. So having a community-based approach makes a huge difference. Now, you can integrate at the state level, but that's really difficult. But you can really do it, and I think this program is showing it, that you can integrate at the community level. You can have your doctors who get paid by different managed care organizations. You can have your area agencies on aging, which are involved in the health homes program we have, which is a care coordination program. We have different people who can be involved and can integrate at that level. So I think there's a real advantage to this program where it actually can have the different qualities that we do need to have. And so I think this has been this has the opportunity to be very effective and from many different perspectives.
Yeah, I'm very interested in, and certainly appreciate your comments and your remarks as it relates to the importance of the at the community level, because I know in certain sectors we have found that while you might deploy a number of care coordinators, they may be focused on just one therapeutic area, or they may be focused on one issue within the delivery system, like a transition, as opposed to what sounds to me to be a more comprehensive approach overall, and the leveraging of that interprofessional team in a person-centered way, considering the needs of those individuals. And it makes sense, since 80% of the way we treat and prevent illness is through medications, that there should be activities surrounding the medication use process. So we look forward to hearing more about the results out of this community. As a physician, can you tell me about that interprofessional team and how you view this working as it relates to the relationship between the primary care physician, say, in some situations, and the clinical pharmacist working in collaborative practice?
Sure. Well, in this program, as you know, the clinical pharmacist is uniquely not on site. I mean, the on-site work is being done by the person from one of the organizations, the outreach person, and they do an excellent job of doing that. They're able to connect, and where they connect with the physician and augment the physician's team is as they connect with them, they develop that trust not only with the patient, but also with the physician, to know that I can turn to Terry in rural resources, or some person that I know now personally, and that person can actually inform me and help me treat that person better. So yes, from a physician's point of view, you want a functional team, and the functional team requires that communications and as you probably have heard, most of our care management done by big corporations is a letter to the doctor saying you should change the medication X for this person, and where they give you a reason, but it doesn't really solve the problems the individual has, which are much more complex than just whether they have the right medication for their stomach or whatever it may be. And it really requires somebody to be really active in that team. So what you have, I think, is the ability to expand the team. We had a good team at Harborview, but we were not able to reach into the community, even there. Here, they've been able to connect the doctors to the local communities and to the patients, and in a way that is really not possible in urban areas, and certainly not in rural areas.
Right. So the three legs of the stool: access, affordability, and appropriateness are considered because of your ability to reach into the community and the way that you have the program structured.
Can I say something about the affordability issue? Because it gets to the payment structure. We have problems with our payment structures. It's so balkanized, and it's very hard to figure out who is really responsible for a patient when somebody has multiple different sources of, I'll say, oversight. And those big companies, the large ones we use, and we have a huge Medicaid program, is, they just do not have the ability to reach into that community and work with it. And we have, I think, the challenge from a state perspective is, how do we take the resources that are now in the managed care organizations? How to take the resources that are through our aging and adult services? And how do we take the resources that are local community resources in the hospital and other places, and actually have them work together and conduit the money in a way that actually supports this on-site personal connection, as opposed to having, say 5 or 6 different people coming at them from different directions and not really being coordinated.
Bingo. I think that's a very good point. I know in some states like Colorado, and then some organizations like the VA, they found that they were in a situation that people were working to coordinate care, but then they had to create a whole nother level of coordinating the coordinators to ensure that the patients could go through the delivery system and or have their needs met in a seamless way. So So kudos to you and the rest of the team for working hard to solve for that, to ensure as we reorganize the healthcare experience for consumers, it's done in a patient-centered, systematic, and coordinated way. And certainly from a medication use standpoint, is done in a way that is more rational than it has been in the past. So hats off to you guys for working to do that. I want to give Jeri an opportunity to offer us a closing comment or a final word. I know, Jeri, you kicked off this podcast, but we'd love to hear from you about your vision for these activities as your state moves forward.
Yeah, thank you, Katie. I appreciate that. And, we're just really grateful to be working with such strong partners like Bob and like Candace and our partners at Rural Resources Community Action and Aging and Long-Term Care of Eastern Washington. And as Bob was speaking to, and as I was speaking to earlier, we are really interested in this idea of community-based care coordination as a powerful tool in the health system to really get at that behavior change and improving health outcomes and improving quality of life for those people who need it most in our communities. And we see this model, this medication care coordination model, as an example of how you can take an integrated approach, integrating those social services, those community-based care coordination services with the health services to really have that powerful impact in communities. And what our vision is really looking at taking a population management approach to health and community in our state and looking at the different communities that make up our region and our state, and having organizations who serve those communities be able to raise their hand and say, this is the community we serve. This is really the shared experience of our community, our strengths, our needs, and we are really best positioned to serve them because we are part of this community and we know this community. And really creating a payment system that those organizations and communities can plug into to be able to be financed for that work. And we really see this medication care coordination program as an example, and the work that we're doing to kind of carve out this pathway as kind of leading of how other communities can be able to plug into a similar system and be able to serve communities who really need care the most in our state.
Thank you. Thank you for those comments. And you couldn't have a better group than the Alliance for Integrated Medication Management to provide strategic program design and management development for these programs. We're delighted that we work with them as partners of the Institute. They're a terrific group to work with. We look forward to hearing more about this great work from the state of Washington. And as you move forward, working with you to share some of the stories like this of your successes. Thank you, Jeri. Thank you, Candace. Thank you, Bob, for spending time with us this afternoon. Hopefully we'll have another opportunity as this program moves along to allow you to report out on these activities and expand these types of services within other communities across our country.
That marks the end of this episode of Voices of Change. Thanks to our listeners for tuning in. To learn more about what you can do to help get the medications right, please visit us at www.gtmr.org. Until next time, be well. As a 501c4 nonprofit, GTMRX relies on financial support from those who share our mission and vision. We would like to thank the organizations who have already pledged their support to our work. These organizations include our founding funders, the American Society of Health System Pharmacists, Johnson & Johnson, and the American College of Clinical Pharmacy. Our executive members, California Chronic Care Coalition, Kaiser Permanente, Tabula Rasa Healthcare, Tria Health, and the Department of Veterans Affairs. And our strategic partners, AbbVie, the American Association of Colleges of Pharmacy, Amgen, Association for Accessible Medicines, Avera, Breast Cancer Index, Cleveland Clinic, Curator, MPRX, Genentech, Genomind, the Journal of Precision Medicine, Kimber Booth, LabCorp, the National Alliance of Healthcare Purchaser Coalitions, OneOhm, Partners in Care Foundation, Fact MI, and the Teachers Retirement System of Kentucky. Their support is essential to advancing CMM.